You know, you always get this token picture of the guy with his duodenum hanging out as your abdominal trauma, but abdominal trauma is not just somebody's got their gut split open and all their entrails are hanging out, right? But that's what you think about when you when you go to treat, because that's a cool injury to treat, right? I mean, what are you going to do for a closed abdominal wound? You're just going to start an IV. That's no fun. But when we're going to start covering organs and seeing their gallbladder and spleen and stuff hanging out, that gets a little bit more fun. With abdominal injuries, the biggest thing to remember is that the chest, organs in the chest and the abdominal organs, they're only separated by one little thin muscle, right? What is that? The diaphragm. So if that's the only thing that's separating them, if you've got a bad enough injury in the abdomen, if you take a hit bad enough, or if you get something happen, that's good grammar, good English, America. If you get some injury to your diaphragm, then you end up having more than just abdominal injuries, right? So it's important to remember that when you're doing your assessment on abdominal injuries, especially when you have the higher up abdominal injuries, to be thinking chest wall or chest stuff too, right? With the types of injuries, most often it's going to be either blunt or penetrating injuries, right? I mean, you could have your lacerations where your guts fall out and all that. Most commonly, somebody's either getting shot, stabbed, or pierced with something, or either they've taken a baseball bat to the gut, or a seatbelt to the gut, or a steering wheel to the gut. There's going to be complications with both of them, and we'll talk about that real quick. Treatment for the protruding viscera. What is the viscera? Right. You got the parietal and the viscera, right? And the viscera is what covers the peritoneum, is what covers the abdominal organs. It's the protector. So if you've got something happen with that, then you've pretty much got your container opened up. And then we know that the abdominal guts are nothing but a bunch of just real malleable organs, right? I mean, they're going to follow the path of least resistance. So anytime you have a breach in the viscera or in the abdominal wall, something's going to happen. Somebody's coming out. Obviously, you would see exterior injuries, but you've got to remember with abdominal injuries that if you see something on the exterior, it's probably going to be bad, and you need to be thinking of what's going on the interior, right? What are the most common exterior signs that you would see that would indicate badness? All right, bruising, abdominal distension, any type of soft tissue trauma, right? The flank bruising, right? Any of those are going to be signs and symptoms. And not only are the things that we see, but we could have a perfectly normal-looking patient, but be in all-out shock, right? Or when I say normal, we won't see any injury, but they may be in all-out shock because the abdomen holds a lot of what? Blood, right? With your intra-abdominal injuries, this is where your good exam's going to come in, right? The thing that we don't do a whole lot, the palpation and the auscultation of the guts, right? This is where a good exam's going to come in, because that's going to be where you're going to find those things that may not show up immediately. Just like with the head injuries, abdominal injuries may not show up immediately. You know, probably the most common thing that you're going to have is abdominal pain, right? They may have a lacerated spleen or a lacerated liver or something like that, you know, one of those solid organs that's very vascular, but the abdominal cavity itself can hold a lot of blood, and it may be bleeding out, but you may not see it yet, right? So that's where you got to get your good head-to-toe assessment, and really important to get your baseline vital signs. Why do we get baseline vital signs? Right. So you can see, like Alicia said earlier, your trends, right? Because I know that if I've got a patient whose heart rate is 75, initially, and then I notice in 5 minutes that it's gone up to 85. 5 minutes after that, it's gone up to 90. Even though they're not markedly tachycardic, I know that they're becoming tachycardic, right? And something's going on. What are going to be your common ALS interventions for abdominal trauma? Yeah, not a whole lot, right? I mean, EMT basic can put a sterile dressing, a occlusive dressing over some guts hanging out just like a medic can, right? The things that you got to think about with this is that, number one, pain management. All right?
I thought you didn't want to do like more things.
Well, I'm getting there.
Something's hanging out.
Yeah. Number one, pain management. Number two, shock. Are they about to go into a shock state? Number three, if they're about to go into a shock state, how much fluid am I going to give them? Because if I can't see that bleeding, obviously I can't control that bleeding. What happens when you give too much fluid? Your pressure's going to go up, you're going to dilute the blood down, and you're probably going to push the clot out, right? For those of you that went through my advanced class, you remember the term permissive hypotension? So where we're wanting to get the fluid up to, or the pressure up just enough to where it's going to circulate a little bit. With the pain management, you typically don't want to do a lot of pain management for somebody that's got abdominal pain, unknown etiology, right? Because it does what? Morphine does what? It's what?
Lowers the heart rate?
It does. It does lower the heart rate, but specifically to abdominal pain, it would mask. A lot of times your abdominal pain, where it's located, is usually going to be in direct correlation with what's going on, right? If somebody says, hey, I'm hurting really bad and my umbilicus is kind of radiating to my right lower quadrant, what are you thinking? Appendix. Same thing, right upper quadrant pain that's circulating around to my back, we're thinking gallbladder, right? So you don't want to mask those. Now, if it's an obvious trauma, you know where that abdominal pain is, right? If their jejunum is hanging out on the pavement, then you know that, hey, that joker's guts are hanging out. I'm no rocket scientist, but I believe that's where that pain's coming from, right? You see what I'm saying? Yeah, I wish I would have thought about saying chitlins instead of. I'll remember that one next time. So trauma kind of takes its own modality when we do treatment, as far as like pain control and stuff like that, right? Again, we don't want to give so much. I mean, obviously, if your chitlins are hanging out, then it's probably going to take a lot of pain management, right? We want to get them just to where they can tolerate it. We're not going to be able to take all the pain away, but we want to get them to where they can tolerate it, because just like you said, it's going to affect your vital signs and stuff like that. So if you've already got decompensation, then you don't want it to go even further, right? A lot of times it's difficult to evaluate just because it won't come up immediately, or we've got these referred pain sites. Remember that term, where you could be having injury in your ear and your left toes hurting? So sometimes it's hard to figure out exactly where it's coming from. My guess would be, though, in abdominal trauma, we're going to treat the whole abdomen like it's injured, right? It says major cause of preventable death would be hemorrhage, right? But if it's intra-abdominal hemorrhage, what can we do? Recognize that, hey, they're bleeding inside, and we need to get them to an operating room immediately, right? That's the only place that's going to be taken care of. Anticipate shock with all abdominal injuries. You know, even those car wrecks where they don't have any type of injury, but that little bruise across their gut, right? Something happened with that seatbelt where it tightened up, right? And it compressed those soft organs. Then infection. You guys know that you got E. coli and all this nasty junk in your gut right now as we sit? So what happens if that stuff gets released into the rest of the body? boom, bam, you're infected. It's bad, right? Also, the inside of the body is used to its regular germs, regular bacteria that helps it. It's normal flora, right? That's why we put sterile dressings over the abdomen when it's opened up. Because if the body's already trying to maintain this balance of this normal flora inside the body, we start getting all this other junk in there, then we've got issues. The anatomy of the abdomen, I'm not going to spend a lot of time on it. Just know that the upper part of the abdomen is probably where the majority of your vital abdominal organs are, where the ones that are going to bleed the worst are. Now, the top part of the liver and the spleen kind of goes up into the thoracic area. So if we've got an injury where it's bad enough to affect the liver or something like that, then we definitely need to be thinking about the thoracic area, right? Now, this is just a asexual being right here. It doesn't show any of the reproductive organs or anything like that. But what are we thinking as far as trauma goes in a female, getting down in the lower parts of the abdomen? Yeah, all those mysterious lady parts, right? And again, Tricia brought up a good point, especially if she's pregnant. How do you find out? You gotta ask, right? Abdominal trauma takes on a whole different meaning with a woman that has a baby growing inside of her, right? Going back to what I said, the thoracic region, this is where the most common life-threatening hemorrhage will occur, would be the liver and the spleen. Number one, the liver is very vascular, so if it gets lacerated, it's going to bleed out a lot. Number two, the liver is the site of a lot of your red blood cell production, right? What do red blood cells carry? Hemoglobin, which carries oxygen, right? Thank you, Alicia. So if, number one, if you've got the liver that's bleeding out a lot, it's hurt, obviously it ain't going to check into work that day, and it's not going to continue to make your red blood cells, right? So you're going to become anemic, twofold, right? You're going to bleed out all your red blood cells, and then the liver's going to be like, "No, player, y'all done hurt me. I ain't making nothing else for you." In the true abdomen, you know, that's what we talk about, the guts, right? Look at a lot of stuff as far as infection goes, because that's where all the nasty stuff hangs out. So if it's hurt bad enough, then that stuff's going to kind of come out. Your retroperitoneal abdomen. What major vessel? You got your aorta and your vena cava, right? Which one are we the most concerned about? We'd be concerned about both of them, but the aorta, right. Then also, you've got your, what? Your kidneys in the back too. Have you ever been punched in the kidneys? It hurts. It hurts. So I can imagine if you get hit with a baseball bat in the kidneys, you probably pee blood for 2 weeks. Blunt injury obviously is the most common with abdominal trauma. Then you got your penetrating. This is where you're going to get cut or shot. Biggest thing again is going to be bleeding or sepsis. Remember the other day when I said you got to be sure that you check out the steering wheel to see if there's any damage to it and all that? The same goes for abdominal injuries too. Lower parts of the steering wheel, I mean, if that joker's been up, that means that they've had some type of pathway that their body somehow is connected, right? So obviously that big ring of steel could do a lot of damage. With your mechanisms of abdominal injury, you've got your direct compression of your abdomen. That's where you just are compressed down. You could either have the fracture or the split of the solid organs, or the hollow organs. What are they going to do if they are under a lot of pressure? Especially if they're full, right? Especially if the stomach's full of food or the gallbladder's full of bile, they're going to pop. Then with your deceleration forces, what is deceleration forces? Yeah, that immediate stop or that twisting or whatever. That's where you're going to get that shearing. And we really worry about what with that? The aorta, right. Then you'll have your accompanying injuries as well. With blunt trauma, blunt abdominal trauma, the liver and spleen are the most common just because, especially the liver is the biggest organ, right? The spleen is the second biggest, and it's got, unless you count your guts and stuff, I mean, they're like, what, 2 miles long or something like that? But talking about all together, it would be the most common one to get hurt. This is important right here, the seatbelt sign. That bruising across the gut right there, right? That gives you a 25% chance that there's an intra-abdominal injury. That's a pretty high percent, right? Also, what does that seatbelt do? It comes down, right? So it goes across the chest, and then it also goes across other parts of the abdomen. So don't leave those out. Pain and tenderness, I mean, that's going to be kind of up in the air, right? I mean, if they've got a lacerated liver, chances are the mechanisms that were strong enough to lacerate their liver is going to be strong enough to hurt other areas as well, right? So sometimes abdominal pain may mask other pain, right? I'm going to look at the projectile and fragments that may hit the gut. Also look for those flying presents that are in cars, because those can do a lot of damage too. This is what we said just a minute ago. Vigorous fluid resuscitation may do more harm. And we said why? PASGs. You know, these keep showing up everywhere, but everywhere you see them, they say, don't put them on. So, why do we still got them? What are you going to do to treat an injury like this, a projectile injury?
Well, it's up in the thoracic region, so inclusive dressing.
Yeah, I would definitely, just in case that projectile went up there and hit the diaphragm, right, I would go ahead and put a occlusive dressing over it. Definitely want it to be sterile though, right? Your primary survey, your DCAP, BTLS, except we're going to look for eviscerations as well. I don't think I need to spend a lot of time on that, right? You know what to look for. These particular injuries, it just talks about the referred pain. They don't understand completely why you have referred pain, but basically what they're saying is that you've got your dermatomes, your nerve tracts that innervate at different areas, and they may end at the spleen, but they may still transmit that pain to another area of the body, and that's why you feel it, right? Definitely want to look out for all the things that we've already said: distension, tenderness, tenseness, all those things that that show you hemorrhage. With the abdomen, like we said, signs don't usually appear just right off unless it was a very, very bad injury, right? It usually takes a little while for there to be enough blood to start accumulating. Now that doesn't mean that their vital signs aren't going to be affected, because bleeding into the abdomen is just like bleeding into the atmosphere, right? Bleeding out onto the pavement. It's not in the vessels, it's not in the cells, so we can't use it, right? So you're still going to see signs and symptoms of shock. That's why those baseline vital signs are very, very important. I can't stress that enough. We're paramedics now. Ooh, whoop-de-doo. We can throw needles in folks' throats and chests and all that, but we still have to give our baseline vital signs. We've always got to refer back to our baseline, right? Because to be a good paramedic, we've got to be a good EMT, right? Always look for shock. The biggest thing, give me 3 or 4 more minutes and we'll be done with this one, alright? The biggest thing with evisceration, I wish I would have put my other slides in. I narrated them. These are exact same pictures. Do you want to shove them guts back in?
No.
No. Is that surgeon just going to kind of throw everything back in and sew it up and all that? Yeah, but we're not surgeons, right? Biggest thing is you want to, or the biggest thing, a lot of big things, you want to be sure you expose the area so you can make sure you get the full picture. So go on and cut that shirt off, right? Saline. Sterile saline or sterile water. You want to soak it. You want it to be moistened. Why do you want it to be moistened? Right, because if it dries off, then you're going to rip their guts out, right? It's going to stick. Then you're going to get that occlusive dressing, and you're going to cover it. It's still an opening in the body, and because of where the abdomen is and the potential for trauma injury, you don't want any type of pressure coming in there, right? You don't want anything coming in. You don't want to stand the chance of anything coming in. So that occlusive dressing has a twofold. The main reason why is because nothing can get through it, right? It's non-permeable. You don't want those nasty things to come in there. For an impaled object, what do you do with an impaled object? Right, what was that little cone called with the penetrating? The cone of injury, right? There's a lot of room for some bad injury in the very soft, weak organs of the abdomen, right? So we want to just control it. We want to stabilize it. Don't move it. Don't pull it out. A couple areas that they're looking at right now, nothing that really applies to us as far as our protocols go, would be the serum lactate levels, which are going to show signs of muscle breakdown, also of sepsis. And then this FAST exam, which is just a ultrasound in the field. All right? Any questions? All right, cool. 12 o'clock on the dot on mine.